Good morning. My name is Carlos Pezantes and I'm going to talk about the oxygen saturation outcomes in preterm infants. I based my article in the Journal of Medicine in the United Kingdom, Australia, and New Zealand collaborative groups. Like an introduction, oxygen is a highly reactive molecule which is essential for life and is toxic in excess. It has been shown that the preterm neonates who have been exposed to an excess of oxygen are more likely to have a chronic lung disease. The continuous monitoring of the saturation is mandatory for all babies under the 32 weeks gestation. Very preterm infants have substantially higher mortality and morbidity than the term infants, partly because they are more prone to respiratory failure and often require mechanical ventilation through an endotracheal tube after the birth. The study problem is that the clinically appropriate range for oxygen saturation in preterm infants is unknown. The trials in the 1950s showed that the unrestricted oxygen increased the rate of the severe growth. However, when oxygen was subsequently restricted, increased mortality was observed. In 3 randomized MACE trials with similar protocols conducted in Australia, New Zealand, and the United Kingdom involving infants born before the 28 weeks gestation, investigators are evaluating the effects of the targeting of range oxygen saturation of the 85 to 99%, as compared with a range of 91 to 95% on survival and neurodevelopment outcomes and 18 months to 2 years. The methods are that the planned study sample size were 1,200 infants each for the United Kingdom, Australian trials, and 340 infants for the New Zealand. Randomization was performed centrally by computer and separately for each trial. In the United Kingdom, a minimizing procedure was used to balance study group assignment according to the sex. The infants were eligible if they had been born within the past 24 hours and before the 28 weeks of gestation. These are the study results in Australia, the New Zealand, and the United Kingdom, and in the combined trials. In the male sex, in the multiple birth, and the use of antenatal glucocortics. And there's the video.
Results in lower systemic oxygen stress and lower incidence of BPD. In the current study, we tested the hypothesis that limiting oxygen exposure at resuscitation in premature infants would decrease systemic oxidative stress as assessed by reduced glutathione to oxidized glutathione ratio, plasma nitrotyrosine, and 8-hydrodeoxyguanosine at 24 hours, 1 week, and 4 weeks of age. This was a prospective, double-blind, randomized controlled trial of administration of 3 specific oxygen concentrations of 21%, 40%, or 100% oxygen at birth in infants less than 32 weeks gestation. Both the FiO2 concentration and the SpO2 recordings were blinded initially and unmasked at 10 minutes of age. We could enroll only 18 infants during the study because of implementation of 2010 NRP guidelines. NRP upper and lower saturation limits are superimposed on the SpO2 curves of the 3 oxygen resuscitated groups. Resuscitation of premature infants with 100% O2, as shown in red, resulted in SpO2 values above the upper limit of the 2010 guidelines in the first 10 minutes after birth. The 40% O2 resuscitated group, as shown in blue, had SpO2 values below the NRP lower limit in the first 5 minutes and within the range by 6 to 10 minutes of age. Similarly, 21% O2 resuscitated group, as shown by the green line, had mean SpO2 values bordering the NRP lower limit in the first 5 minutes and within the NRP-defined SpO2 target range from 6 to 10 minutes. However, our numbers were small to make any definite conclusions. Despite aggressive weaning, FiO2 was significantly higher in the under 100% O2 group to maintain the target SpO2 until 30 minutes of age. There was no significant difference in FiO2 between 40% O2 and 21% O2 groups during the weaning process. GS&GSSD ratio was significantly lower at 24 hours in the 100% O2 group compared with 21% O2 and 40% O2 groups, suggesting higher oxidative stress in this group. The ratio was not different among the groups at 1 week or at 4 weeks of age. Plasma nitrotyrosine, a marker of peroxynitrate formation, was higher in the two oxygen-resuscitated groups over time. Also, 100% O2 group had higher nitrotyrosine compared to the other two groups at 24 hours. 8-hydrodeoxyguanosine levels were similar at 24 hours and at 4 weeks among the groups. However, 8-OHDG levels were significantly higher at 4 weeks compared to 24 hours among the groups. To conclude, we have defined the natural evolution of SpO2 in the first 10 minutes of life with exposure to 3 different concentrations of oxygen. Randomization to higher FiO2 led to higher total oxygen exposure at resuscitation, and this was significantly correlated with markers of systemic oxidant stress. Although multiple studies have addressed issues involving oxygen at resuscitation, the novelty of our study was in keeping the oxygen concentrations constant at resuscitation. Thank you.
And continuing with the article, we are going to talk about the enrollment and the treatment. To master the study oximeters were modified internationally so that readings of 85 to 95% showed an oxygen saturation that was either 3% points higher or 3% points lower than the actual value. To achieve the intent oxygen saturation range in either group, clinical staff members started display readings in the range of 88 to 92%. Like a note, the only study oximeters were used from the time of randomization until the 36 weeks of gestation. The assessments. Data were recorded on case report forms at each center and checked centrally. The rope was classified according to the International Classification of Retinopathy of Premature. Neck was listed if it required surgery or cause of death. The oxygen treatment at the 36 week was recorded in all the 3 trials. The study results, a total of 448 infants were enrolled in the 3 trials, 973 in the United Kingdom, 11,035% in Australia, and 340 in New Zealand. The rate of death. Among 1,187 infants from whom the revised oximeter calibration algorithm was used in the lower target group had a higher rate of death than those in the higher target group before the hospital discharge. In all data combined, there was no significant difference in the rate of death in the lower target group as compared with the higher target group, and 90.2% versus 16.6%. Although the significantly fewer infants in the lower target group were treated with oxygen at 36 weeks with 3 trials. There were more deaths in the lower target group, but no single cause dominated the difference. This is a video about the control of the oxygen saturation in the preterm infants.
may be one of the most valuable, called pulse oximetry. A cheap, non-invasive test checks for serious heart defects.
We put a oxygen saturation probe on one of their fingers on the right hand, and then another oxygen sat probe on one of their feet, and we just measure their oxygen levels.
Heart malformations are the most common kind of birth defect, affecting an estimated 1 out of 100 births worldwide. In 25% of cases, the defects are life-threatening, but the diagnosis may be missed because in the first few days of life, nothing may look or sound wrong.
The signs of a critical congenital heart defect vary tremendously, and they vary from a patient being extremely sick and being cyanotic or blue, or to a patient that looks fine and is feeling okay.
Screening costs about $1 per baby, takes only seconds to perform.
We record the stay with their mothers at all times, so we take the equipment into the room.
Using a Band-Aid-like wrap with a light sensor inside, technicians look for oxygen levels below 90% or a discrepancy of greater than 3% between hand and foot. These raise a red flag.
This test has a strong ability to detect things that have the defect.
Most states require a pulse oximetry test before babies go home. Florida does not, but the Memorial Health System has made it a system-wide policy.
Assuming that we identify that an infant has a defect, the more appropriate treatment that can be instituted, and the better outcome for the infant.
For the Memorial Health System, I'm Amy Osher.
In a conclusion, we have that between the group difference in rate of death occurred over the many weeks of the intervention and was not attributable to any single cause of death. It is unclear why the rate of death was higher in the lower target group than in the higher target group. Detailed analysis of the oxygen saturation patterns of infants who survived and died will be required to further explore this issue. In the pooled data, the lower oxygen saturation targets significantly increased the rate of necrotic enterocolitis requiring surgery of causing death. This definition excludes the milder cause of necrotic enterocolitis with more subjective features. It is plausible that a lower oxygen saturation might influence bowel ischemia. In conclusion, the preterm infants born before the 28 weeks gestation with a target oxygen saturation of 85 to 89% had a significantly higher rate of death than did those with a target of 91 to 95% in a subgroup dose. Treatment involved an oximeter calibration algorithm similar to that in the current use aid. Our findings strongly favor the avoidance of the targeting of oxygen saturation of less than the 90% among such infants according to the readings on our current oximeters. Thank you.